All right, so let's talk about embolic agents to use for PAE. You had mentioned that you prefer 300 to 500 micron particles. That's what I'm using as well. Just for me, it's just that in coils. You hear about people using liquid embolics. You had mentioned that and smaller particles. Are there ever any circumstances where you're using either of those, anything smaller or liquid?
No, not really. Not after all the data that's been out there for smaller, unless you have a patient that you're retreating for whatever reason, or they've already undergone previous surgical therapy, and then those vessels can get very dicey and they're very small. And we've had good results in patients that we retreated after Urolift failures or green light failures or other things like that. But those vessels could be smaller and friable and thus require different tools. But in those cases, the other thing that we've noted, and we'll be publishing this pretty soon, I think we shared it at Guest last year, is those patients tend to have a lot more collaterals. And
Interesting.
So you have to be really vigilant about coiling and looking out for non-target embolization in those patients, because after they've been resected or partially resected, what have you, at the blood flow and vascular anatomy changes quite a bit.
Yeah. That's interesting. I didn't realize that after, Urolift, et cetera, they get more collaterals. I don't think I've had to retreat any of those. What you mentioned that those arteries can be a lot more friable and presumably more tortuous. How are you treating them differently?
So, typically, all of the same tools we talked about with cone beam and everything like that. Very aggressive with the vasodilators.
Okay.
Very aggressive with coil embolization, because we find collaterals to the penis, bladder, rectum, everything that you can imagine. They're going to be collaterals. Basically, and the vessels are usually much smaller and more wispy and friable. There's a lot more. Instead of a big single artery, there might be a lot of tiny little branches going to the tissues. So it can be very challenging, but the patients do really well after the treatment. It's just a little bit more meticulous work is required to do it safely. And so very liberal with use of coils, very liberal with use of vasodilators, and getting a lot of good angiographic images to make sure that you're not hitting anything that you don't want to hit in the wrong target bed.